So Scott is a final year PhD student at the Center for Health, Exercise and Sports Medicine at University of Melbourne in Australia. He received Bachelor of Biomedicine in 2014 and a Doctor of Physiotherapy in 2017, both from the Uni of Melbourne. His research involves the use of EMG-informed neuromusculoskeletal modeling to evaluate the effects of self-management interventions on estimates of knee loading and muscle force in people at risk of and with established knee osteoarthritis. Scott also works concurrently as a musculoskeletal physiotherapist, where he has a special interest in knee rehab. Scott, floor is yours.
A few tongue twisters there, Tom Slav, I apologise. Honoured to be talking amongst some very highly esteemed academics. As Tom Slav alluded to, I'll be chatting to you about some of the work I've done in my PhD, looking at EMG and subject-specific musculoskeletal modelling, particularly looking at interventions in people with knee osteoarthritis. So knee osteoarthritis. Well, osteoarthritis is a complex and disabling chronic disease that affects movable joints. And the knee is one of the most commonly affected in osteoarthritis, with a prevalence of 1 in 5 people over the age of 50. So considering the tibiofemoral joint, osteoarthritis is most common in the medial compartment, with a prevalence of 5 to 10 times higher than the lateral compartment. And for individuals, the burden of knee OA includes pain, impaired physical function, and reduced quality of life. But the disease also has a substantial burden on the Australian healthcare system, with direct costs estimated to reach about $2.9 billion annually by 2030. So how does a knee on the left here become a knee on the right here? Well, there are many complex interrelated risk factors that likely drive the onset and progression of medial knee osteoarthritis. So these factors include local factors such as varus malalignment, past joint injury, increased joint loading and lower limb muscle weakness. However, they also include systemic factors such as age, genetics and gender. But importantly, many of the local factors are mechanical in nature, which dictates the need for appropriate biomechanical interventions to modify them. So there are quite a few biomechanical interventions that are considered for knee OA. And in simplistic terms, they intend to target the risk factors of elevated joint loads and lower limb muscle weakness. So, for example, we try to increase lower limb muscle force production via strengthening exercise. Hopefully you can see my mouse here. Or we try to reduce knee loads through interventions such as valgus bracing, heel wedges, certain shoe types, and gait retraining with biofeedback. So how are we currently evaluating the influence of such interventions on muscle force and joint loading? While considering medial knee loads, external moments such as the knee adduction moment are the most commonly used methods. However, these moments have a weak and variable relationship with in vivo knee loads, particularly during tasks that are more vigorous than walking, such as exercises. And likewise, EMG activations are commonly used to infer muscle force. However, these are only indirect measures, given muscle activation and force production has a non-linear relationship. Static optimization is another commonly used method, very useful. It estimates muscle activations based upon an objective function in the absence of experimental EMG data. However, by definition, static optimization will minimize co-contraction of agonist and antagonist muscle groups by assuming an optimal neuromuscular control strategy. So this forms a bit of an issue for evaluating tasks that involve a high degree of co-contraction, such as weight-bearing exercise, and in clinical populations such as knee OA who have abnormal muscle activation patterns. So now moving up the hierarchy and becoming much less common, we arrive at electromyogram-informed modelling. So these methods use experimentally collected EMG data in combination with muscle tendon unit kinematics and joint kinematics to calculate muscle forces and joint contact forces. How does it work? Well, here's an example of how we perform EMG-informed modelling. in our studies. So essentially we collect a gait task, whether it's walking or exercise. We have surface EMG of lower limb muscles, and we also have motion capture data, so marker data, ground reaction force data. We process this data in a MATLAB toolbox called Moto-NMS, and we then normalize the EMG data to maximal velocity isometric contractions over some standardized tasks to get an activation between 0 and 1 to use in our modeling. We can't just use raw EMG, that's not going to work. We then take, with our modeling, so we take a generic full body musculoskeletal model by Rajagopal et al. Is the one we use, and we linearly scale the lower limb muscle segment dimensions and mass properties using the distances between pairs of markers acquired during a static pose. And now, given that this scaling does not necessarily maintain dimensionless muscle fiber and tendon operating ranges, we optimize these based on some work done by Luca Modenese et al. And we also adjust the maximal isometric force output using some regression equations. So once this model is finalized, we then run inverse kinematics, inverse dynamics, and muscle analysis tools within OpenSim to determine the lower limb kinematics, joint moments, and muscle tendon unit kinematics. So where's my mouse gone? Here we are. So the resulting modeled external joint moments, muscle tendon unit kinematics, and the normalized EMG here are then used to calibrate an EMG-informed neuromusculoskeletal model for the participants to estimate muscle forces. And we use a toolbox called CNMS in MATLAB, which was designed by Claudio Pizzolato et al. A few years ago. And specifically, we use an EMG-assisted neural control algorithm outlined by Sartori et al. To synthesize excitation patterns for non-instrumented muscles such as sartorius and gracilis. So then to look at our contact forces, we take the resulting CNMS estimated muscle forces and the modeled OpenSim external moments, and we input them into a planar mechanism designed by Winby et al. In 2009. We use this to estimate medial contact force. And essentially what this mechanism does is it assumes equilibrium at each instant in time, such that the external moments here around one contact point must be balanced by a combination of muscle and external moments about the opposite contact point. All right, hopefully that wasn't too much of an earful of methods. But when we're looking at EMG models, they can be personalized beyond our standard motion capture using medical imaging such as MRI or CT scans. And generally, the evidence suggests that these personalized models improve predictions of joint contact force compared to scaled generic models. However, when we're looking at extending these models to MRI-informed lower limb muscle architecture, there's really not a convincing rationale that we're going to get more specific and more accurate estimates between these two. So subsequently, generally, our personalization is limited to bone geometry in the NEOA literature, given these time demands and cost versus time, as has been well discussed in our previous talk. So how do we make these models geometry specific? Well, we get a lot of useful information from these MRIs that we segment. So we use mimics to form a 3D reconstruction of the lower limb. We then use standardized anatomical landmarks to find the joint centers. Particularly important looking at the hip where you've got a lot of adipose tissue floating around. We really want to get a nice specific point for the hip joint center to get accurate moment estimates. Similarly, we want to be making sure that we're getting, accurate widths and bones of the pelvis and the shank and the femur. But last and probably most important is looking at the contact points between the femur and the tibia. So we do this by forming an extremer analysis, so looking at the most distal point in the medial and the lateral condyle, And essentially, this is what informs this planar mechanism here. And there's evidence to show that, for every millimeter discrepancy between here, you're changing the first peak contact force by about 41 newtons. And if you consider an average 70 kilo human, that's about 3 or 4% error in peak contact force for 1 millimeter, which we can't really get through regression equations using marker data on the femoral condyles. So in the second half, I'm now going to briefly discuss two studies where I applied this EMG-informed modelling with subject-specific bone geometry to evaluate two biomechanical interventions. So the first one's going to look at examining the effects of two shoe types on medial contact force, while the other is going to examine muscle forces during certain weight-bearing exercises. Alrighty, shoes for knee OA. So there's two main shoe types that we're looking at for knee OA. Got our flat flexible shoes here and stable supportive shoes on the right here. And these are quite different shoes, as outlined by classification criteria by Patterson et al. In 2017. And essentially they differ based on heel thickness, shoe pitch, so a stack height between the heel and the toe, the rigidity of the soles, so you've got a very flexible shoe here, hopefully it starts playing, compared to a really rigid shoe here. Looking at our motion control properties, so basically the stable supportive shoe is able to resist pronation and supination of the foot, while the flat flexible shoe really has none of these motion control properties. And lastly, shoe weight. So you've got quite a heavy shoe compared to a light shoe. So is there a rationale for one shoe type over the other? Well, there is. It's a biomechanical rationale. And essentially the rationale is that the knee adduction moments will be lowest in barefoot walking, and any shoe you put on is going to increase the knee adduction moment. So theoretically, we want to be wearing shoes that are most replicating barefoot or the flat flexible shoes. And that's been demonstrated by ranges between 6 to 14% increases in the peak cam in the stable supportive shoes compared to the flat flexible shoes. However, a recent RCT actually found that the stable supportive shoes improve pain compared to the flat flexible shoes, which is basically contradicting the current biomechanical rationale. So what we did is we had a look at applying our EMG-informed modelling to these two shoe types. So we took 28 participants with medial knee OA, aged over 50 years, and essentially we got them walking firstly in a flat flexible shoe, and then in a stable supportive shoe in a randomised order. We performed our EMG-informed modelling on it, and then we analysed the waveforms using statistical parametric mapping, and then we looked at the discrete variables as well. And essentially what we found is here we have the waveform figure of the contact force across the stance phase of gait. Green is the stable supportive shoe, yellow is the flat flexible shoe. Essentially what we found is during the loading phase of stance, so this early phase here, the stable supportive shoes actually reduced the contact force compared to the flat flexible shoes. And when we're having a look at our discrete outcomes, that came out as what we would call a reduced loading impulse and a reduced loading rate. So this slope here was shallower with the stable supportive shoes, which was a novel finding, given that originally we were seeing quite a large discrepancy between the peak cams here. Why did this happen? Well, we think it's probably got something to do with the shock absorption capacity of the shoes. So we're looking at a shoe here with very thick, high soles, cushioned soles, as opposed to very thin, low-pitched heels with minimal cushioning here. And that's probably what was driving this kind of delayed response in the contact force. Is this clinically meaningful? Who knows? We need to do some further studies to find out. But certainly, when we're looking at our CAM data for this study, we found very similar results, such that the stable supportive shoes increased the peak CAM by about 8%. However, we really found a negligible change in the peak contact force, which kind of just reinforces the fact that you can get changes in these external loads, but you might not get changes in the contact force, whether this is due to changes in muscle or changes in the way they're walking. Very important to note. All right, hopefully I have time. Thomas Lav, please let me know. The second example we're going to be looking at is examining the muscle forces during weight-bearing exercises. So briefly, what we have is weight-bearing exercises often prescribed to people with knee OA. And they're thought to integrate multiple muscle groups and be more reflective of functional movements such as walking than alternative such as non-weight-bearing quadriceps strengthening exercises. However, we don't really know if these exercise function is intended. No research has really compared the various muscle forces that are undertaken during these exercises to those of daily activities such as walking. So that's what we performed in this study. So we took the same group of 28 people with medial knee OA. Hopefully these will load throughout the talk. And basically we got them to perform 3 exercises: a single leg heel raise, a double leg squat, a forward lunge, and then we got them just walking. And we compared the individual lower limb muscle force groups from these different exercises to walking. And what we have here are our waveform figures of knee extensor force. We have grey is squat, yellow is lunge, bluey green is the heel raise, and this dashed line is the peak during walking. Now what we found is that compared to walking, the peak extensor force was about 3 times higher during walking and squatting and lunging. And the knee flexor force was about 1.6 and 2.5 times higher during lunging and squatting respectively. And here we have just the individual participant data for the peak knee extensor force and the peak knee flexor force. I mean, you might say to me, oh well, Scott, these are quad dominant exercises, is what we expect. But these are findings that have never been proven before. And generating these forces is really important, given that we know that the quads and the hamstrings stabilise the knee during that early half of stance phase. So conversely, we also had a look at the ankle plantar flexor force, and what we found is that none of the exercises increased force compared to walking, which is quite an interesting finding, given that one of the exercises was a heel raise, which specifically targets ankle plantar flexor force. So really, based on these conclusions, these findings, we would suggest it's not worth including such an exercise as a strengthening program, unless you're looking at starting as a progression, maybe holding weights, or maybe doing a bent knee to recruit soleus a bit more, produce a bit more force, as Panda alluded to earlier. But similarly with the hip abductor force, none of the exercises generated a peak force larger than walking, which again probably suggests that we might want to be looking at more targeted hip strengthening, either sort of banded resistance exercises, like neuromuscular exercises, where we really try to specifically target pelvic stability. But yeah, another really interesting finding. So just lastly, looking at some future research directions. So really, these 2 examples sort of highlight the capacity for EMG-informed modelling to help refine biomechanical interventions for knee OA. So for example, we can conduct further research to modify or add features to the stable supportive shoes to augment the observed load reductions that we found. And yeah, while these findings do agree with the RCT favouring these shoes to reduce pain, this is really only a postulation. So we don't really know if these pain relieving effects are being driven by changes in joint load. So really future research needs to examine whether these changes in joint contact force can generate meaningful improvements in clinical outcomes such as pain. And the final consideration is we were really looking at sort of absolute net compartment loading using this mechanism. How it's plausible that we might want to be also looking at regional loading as well. So how does the load change across the compartment? And there's some evidence to suggest at the hip that people with femoroacetabular impingement walk with lower neck compartment loading at the hip, but they have more concentrated regional loading that is located more anteriorly and laterally on the acetabulum. But there's also evidence to suggest that if we activate the deep hip muscles, we're able to change this regional loading. So based on these findings, it's possible that we might be able to change regional loading at the tibiofemoral joint as well, akin to what's observed here. But we really need to be validating this further. And luckily, moving forwards, there's some really exciting pipelines being put together with finite element analysis modelling, which might suggest that we can look at both regional and net magnitude loading in these clinical populations. So in summary, EMG-informed models with subject-specific bone geometry play an important role in extending knowledge about the effects of interventions on joint biomechanics in people with medial knee OA. However, to move forward, these methods really need to be validated and integrated within larger scale clinical studies to ultimately give clinically meaningful information to clinicians and their patients. I'd like to acknowledge my co-authors and thank you.
Thank you, Scott. That was very interesting. We are running a bit late, but we do have a time for a question if there is. Are there any questions online? So I'll have one. Marcus said that in the first talk that there are muscles don't necessarily need to span the joint to actually affect the joint. You did tests which where you were measuring muscles spanning the joint and they didn't they were not affected by the exercise that was supposed to affect them. What do you take from that? Like, how is that possible?
It's a little bit challenging, and it's certainly the hip plays an important role in dictating load. But I think the hip, those muscles have more of an inertial role in dictating the load. When you break it down to an absolute perspective, it's going to be the knee spanning muscles physically compressing the joints. If your hip abductors are firing more, yes, that's going to bring the knee out into abduction, and that's going to compress the medial joint, the medial compartment. So I think it's that combination of working out what muscles we want to be strengthening, what muscles we want to be working on coordinating a bit better. And there's certainly things we need to be looking into further. And it's also quite challenging when you're looking at the interplay between loading and muscle weakness. How do you increase muscle force without increasing joint load, and how's that going to interact? So it's quite a complex interaction.
Yeah, indeed it is. Thank you. So let's just thank Scott for his talk. Yeah, so we are a bit late. Sorry for that. We have a coffee break now, which should have gone from 3:15 to 3:30. Now it's 3:25. Let's make 10 minutes so that we are not late too much. And let's come back in 10 minutes and we'll continue. So we have 4 more talks and a panel discussion. Thank you.